We all have our own notion of what the ideal anesthetic is, and for each of us it may be a little bit different. Might be different for me and for you. But the only important person is the patient, isn't it? So let's ask the patient, what is the ideal anesthetic? From the patient's viewpoint, the ideal anesthetic is, well, it's one that doesn't produce any vomiting. It's one that doesn't produce any gagging on the tracheal tube, or incisional pain, or nausea, or recall. Patient wants to be amnestic. Those are the 5 issues most important to the patient, as defined by simply asking the patient, what's important to you? There is no ideal anesthetic. There is no anesthetic that's going to supply with absolute assurance all of these qualities. Desflurane is not the ideal anesthetic. Sevoflurane is not. Isoflurane is not. Propofol is not. Remifentanil is not. I would argue, though, that the ideal anesthetic can be approached most closely by combining the best qualities of several anesthetics and anesthetic adjuvants that are tailored to the particular needs of a patient. And what we're going to talk about is a recipe, or perhaps a recipe with variants, that approaches the ideal. It includes all aspects that surround the anesthetic experience, from pre-medication to recovery. What are we trying to do with pre-medication? What is it that is the principal thing we're trying to do with pre-medication?
Relieve anxiety.
That's it. That's it. We're trying to relieve anxiety. And there are a couple of ways we can do that. We can do it psychologically, or we can do it pharmacologically. Now, if we're doing it psychologically, let me urge you to do some things. Introduce yourself. Identify yourself. Touch the patient. Hold the patient's hand. And have confidence. How do you indicate that you have confidence? Well, you talk to the patient in a voice that doesn't indicate that you're as terrified as the patient is. And to do that, you keep the pitch of your voice down, and you don't talk loudly. I find occasionally that a resident will think that a patient is deaf, and it's because the resident is anxious. You've got to have confidence. You've got to have confidence that you are the best anesthetist in the world. I have that confidence. I know that I am the best anesthetist in the world. It's a bit of arrogance, but it serves me well in terms of coming to a patient. I know it's not true. Intellectually, I understand that several of you who have gotten more practice in the last month than I have delivering anesthesia are probably better than I am. But I've got the arrogance to think, to believe, to have the emotion that I am the best anesthetist in the world. And you should have that too. Have that confidence when you approach the patient. And of course, if all else fails, you've got the 2 milligrams of midazolam, right? Okay. So we can achieve that decrease in anxiety. And I find it a delight to do that. I find it a delight to go to a patient who's terrified, and end with the feeling that I have made that patient calmer. I've made that patient ready to accept the operative and anesthetic experience. And usually we combine the two. What's the price we pay for giving the 2 milligrams of midazolam? Well, it's got a tail to it. It's got a residual. I showed you that it might delay recovery from anesthesia. It might cause some desaturation in the holding area, and it has a price, an acquisition price. It just costs money to give midazolam. Do we have to give midazolam to all patients?
No.
No, we don't have to. Well, there's no law that says we have to give it, but beyond that, in order to allay apprehension, do we have to give it? No. Some patients are reasonably phlegmatic. Let's start looking at such a patient. Let's see how Tracy established rapport with a patient.
Paul. Hey, I'm Dr. Cole. I work with anesthesia, and this is Dr. Eager, one of the attending physicians. We're going to be back in the operating room with you during your surgery.
Okay.
Can you tell me some things that concern you about waking up from your surgery or during your surgery?
I just don't want to be nauseous. That's the only thing.
Afraid of having any pain?
Yeah.
A little bit, okay. And are you anxious at all?
That patient, who happened to be a medical student incidentally, told us that he wasn't anxious. And we took him at his word, didn't we? And we didn't give him any midazolam. Okay. Now let's go to induction of anesthesia. What are we trying to accomplish with induction of anesthesia? Say the obvious.
Quick onset.
We're trying to accomplish a quick onset, a rapid transition from the wakeful state to the anesthetized state. Why are we doing it quickly?
Well, I don't know. I mean, we're waiting. The surgeon possibly is waiting. We need to
Yeah,
get.
they're economic and social issues that impel us to induce anesthesia as rapidly as is safely possible. There was another comment. Yes, please.
I was going to say we want to pass through stage 2 anesthesia as quickly as possible because that's our highest risk for laryngospasm. And also if we reduce the transition time, we reduce the length of time where regurgitation could possibly occur.
And those are good points. Those are good points. So we want to move quickly through the induction process. And we want to anticipate things. What do we want to anticipate?
Airway compromise.
Airway compromise. And go beyond that. Look down 10 minutes down the road, or 20 minutes, or an hour, or 2 hours down the road. What else do we want to anticipate?
Well, hemodynamic stability or instability, you want to...
Right. You anticipate you're going to maintain anesthesia.
Right.
You anticipate you're going to do things that traumatize the patient. You might place an airway. You might place a tracheal tube. You've got to anticipate that surgery may be coming. And all of these things we need to consider. What are the two approaches we might use to induction of anesthesia?
Inhalation or intravenous.
There we are, inhalation and intravenous. Those are the alternatives that are available to us. If we talk about inhalation, we're talking about halothane or sevoflurane. At this institution, you've opted for sevoflurane for, I think, very good reasons. If you don't want an inhalation induction, you want an intravenous induction, as far as I'm concerned, you're opting for propofol or methotrexate. Compounds that allow you a quick in and also a quick out. We use an intravenous approach for several reasons, and these are the ones that are commonly given. It is quicker, and that's been demonstrated in several studies. It's smoother. It doesn't impose the claustrophobia that an inhalation induction can impose. If we're using propofol, it, at least for a time, is an antiemetic. It produces euphoria on awakening, at least a small element of it. And if we want our patients to pay their bills, euphoria is a very good thing. And patients prefer it. They say they'd rather have an intravenous induction to an inhalation induction. We talked a moment ago about what we should anticipate. The first thing and most important is the transition. And we want that to be rapid, as was suggested. We need to consider the immediate needs of surgery and anesthesia, the tracheal tube, or the LMA, and the incision. And we need to look ahead to recovery from anesthesia and not do things that will impair recovery. That's going to be determined a little bit by the duration of the anesthesia. If it's going to be a brief anesthesia, we may be more concerned about what we do during induction as it may affect recovery than if it's a prolonged anesthesia. Let's look at the induction that we accomplished with Tracy.
Still just filling your lungs with oxygen. I'll let you know when you're going to go on off to sleep. I'll give you some medication through your IV that might sting just a little bit. That'll go away as you go on off to sleep. I'm going to take good care of you. Nice deep breath. Another deep breath for me, in and out. Deep breath for me.
I think he is out of contact now. He lost his lash? Not quite.
Just a little bit.
Just a little more.
Still breathing a little bit.
Well, I think he's apneic now.
Paul, can you open your eyes? Okay, I think we're ready.
You're going to use the brain technique?
Yes, I am.
Okay.
Okay, we need the syringe.
Okay. And you want to give nitrous? You're going to go for 3 and 2. You ventilate him easily? That's
Yes.
good too. You have much of a leak?
I don't think so.
And he is breathing. So they could proceed with their things. We started our inhaled anesthetic. What did you do then?
I turned the desferrine up to 6%.
You a little concerned about that?
No, because at concentration 6% or below, there really isn't any incidence of coughing or cardiorespiratory response.
So that's our safe concentration. What did that produce in the way of an end-tidal concentration?
Well, right now you can see his end tidal is 4.5%.
Okay. And you've got that in how much nitrous oxide?
I have 3 liters of nitrous and 2 liters of oxygen dialed in here, which is 60% nitrous, and the end tidal is reading 50%, 49, 50%, which is the goal.
So you want 50%.
Right.
And yet you're giving 60%. How come you're only getting 50%?
This is the beginning of the case, and the patient's taking up nitrous oxide.
Okay. Now, is that going to be enough anesthesia for this young man who's 26 years old?
Given the fact that he's 26, his MAC of desferrine will be about 7%. So we have given him the propofol. He has had fentanyl as well, but that will start increasing with the dialed concentration.
So what else is contributing to our anesthesia besides the desferrine and the fentanyl and a little bit of propofol?
And the nitrous oxide.
And the
So
nitrous oxide.
the MAC value here is actually reading 1.3%.
We induced anesthesia with propofol. And we added some lidocaine to the propofol. Why did we add the lidocaine to the propofol? What was that?
Thought to make it less irritating by making it less acidic.
By making it less acidic. And how much fentanyl did we use in that case? How much fentanyl was given for induction?
Can't remember if we used 50 mics or 100 mics in this patient.
We used a very small amount.
Mhm.
I think no more than 50. Why would you use a small amount?
Because you want the patient to breathe spontaneously with the LMA in.
Right. So we were concerned that we didn't want to depress breathing and have to support ventilation ourselves. We wanted the patient to be breathing spontaneously. How much propofol is needed to introduce an LMA? Can you do it with 1.5 mics per kilo? Well, you can, but it's harder. And we chose to use about 2 mics per kilo, didn't we? He weighed, close to 180, 200 pounds. I've forgotten the specifics. It was 2 or a little bit more than 2 mics per kilo.
Milligrams per kilogram?
I'm sorry, milligrams per kilogram. Thank you. Off only by 1,000. Okay? What if we gave 3? I mean, if 2 is good, wouldn't 3 be better? What's the concern about giving a little bit more?
Hypertension.
You get hypotension. What else?
Have a delayed response as far as spontaneous respiration coming back.
Yeah, so you wouldn't have spontaneous ventilation, which was another aim. We wanted to continue the spontaneous ventilation. We had it almost throughout the period of induction. Okay, and Tracy wasn't fearful about turning the death range immediately to 6%. Why was that? Why weren't you concerned about turning the death range to 6%?
Because at concentrations at 1 max 6% or less, you're not going to have the cardiorespiratory stimulation.
Yeah, there isn't an issue of pungency, and there isn't an issue of tachycardia and hypertension. Okay. We added 50% nitrous oxide. Why do we add 50% nitrous oxide? Why is that part of the ideal anesthetic?
Speeds induction.
It may speed the induction a little bit, although we got a pretty fast induction with just the propofol.
True.
What else? What else is
I
important?
think if you go above 50% concentration, it increases your risk of nausea, I think.
So you stayed at 50%. That's right. So you don't go above 50%. Well, why give 50%? Why not give none at all?
Well, that way, because we know his MAC is going to be a little bit higher because of his age. So if you go ahead and go up on the nitrous, that way you can actually run maybe a little bit less deaths.
Okay.
I was just going to say, anticipating emergence, the MAC-away to MAC ratio for nitrous is going to be higher than if you're just using desflurane.
Yeah, so we're looking ahead. And we're going to not just give it for induction, we're going to give it for the whole thing. And 50% is going to help us on the recovery. Now, maintenance of anesthesia might be divided into before surgery and then after surgery, because the stimulus and the cardiovascular response are going to be different in those two areas. Let's look at maintenance now as we had it, Tracy had it. That blood pressure has come down from what we started with, hasn't it?
Yes, it has. At the beginning of induction, his blood pressure was about 150 over 80, and you can see it's 114 over 55 now.
So that's come down quite a bit. Are you concerned about that?
Not in this 26-year-old patient who's about ready to have stimulation from surgery.
So we anticipate that's going to go up.
Right.
All right. Okay. Now, right before the surgical incision, his end-tidal CO2 was 55 millimeters of mercury. Doesn't look like it's changed very much.
No, it hasn't.
So the stimulus of surgery hasn't really caused that to change. And the blood pressure also hasn't changed very much.
No.
So we must have a pretty adequate level of anesthesia. Are you concerned about that high end-tidal CO2?
No, I'm not. The patient's breathing spontaneously and well saturated, and if it continues to climb, the patient will become apneic and not continue to take up anesthetic, or anesthetic will not continue to go into the lungs.
So there's a sort of a negative feedback that limits how much it will go up.
Right.
Now, we've been going for about 20 minutes, and do you think we could reduce the flows and save a little of the governor's money?
I think so.
What are you going to lower them to?
I'm going to go down to 60% nitrous and 40% oxygen.
At a 1 liter total flow?
Right.
Okay. The desflurane concentration is up at 4.7%. Do you want to lower that?
I don't want to lower at this point because I've just lowered the flows, which will lower the desflurane.
By the uptake, the greater uptake as a proportion of the total inflow.
Right.
I think that's right. So we'll see that come down from 4.7%. Where would you like it to come to?
Probably about 4% or slightly under.
I think that'd be a good concentration, especially with the fentanyl and the nitrous oxide that we have. That 1 liter per minute seems to work pretty well. Do you think you could go even lower than that?
Sure, we can go lower. I'll turn it down to 300 of nitrous and 400 of oxygen.
Could you go lower than that?
Probably not too much lower than that.
Why is that?
Well, the patient's oxygen uptake is about 200 to 250 cc's, and he's taking up desflurane and nitrous oxide, and then he's also losing gases to the analyzer.
So all that may approach 700 cc's.
Right.
How will you know when you've gone too far?
Oh, the bag won't fill and the patient will stop breathing.
I guess that's right. Got no gas to breathe, can't breathe. You may have noticed that with the onset of surgery, there wasn't much in the way of a response initially, but with the passage of time, that end-tidal CO2 went from 55 down to 48. The stimulation did indeed increase ventilation. It also, I think, increased blood pressure a little bit, but I don't remember the specifics of that. You have any remembrance of that, Tracy?
I couldn't say. I think it increased a little bit, but I don't know to what
Okay.
value.
Okay. Now, we may need to give drugs during maintenance. We may need to give more fentanyl. What would be the indication for more fentanyl? What would you say, Tracy?
The heart rate or blood pressure increased.
So if the heart rate and blood pressure increases more than just a little bit, it might indicate that we don't have a sufficiency of analgesia.
Right.
And you might give fentanyl. How much would you give?
I'd probably only give about 25 micrograms at a time.
Why is that?
Because if I can always give more if I need to, and if I give more initially, it might knock out his respirations.
Which we don't want to
Right.
have happen, particularly with an LMA. Do we have any coughing with this LMA thus far?
No,
Not even once?
not that I recall.
Any laryngospasm?
No.
No? Any increase in secretions? Not that you remember,
not
but
that
you
I-
don't remember anything about it anymore. Okay.
It's been a while.
Right. No, it was totally uneventful. So we give this terribly pungent anesthetic, and nothing happens. Given via an LMA. Okay. Now we have to also anticipate that the anesthesia may get lighter. We decrease the flow rate, and the anticipation was that the concentration of desferrin would go down in this young man. And we don't want this young man moving his knee in the presence of his arthroscopy. So what's our insurance policy there? How are we going to deal with that possibility that he might suddenly move if we got the anesthetic too light?
Well, if we got it too light, I always have some more Propofol.
You got that insurance syringe of Propofol at the ready. You don't need any more lidocaine in that, though, do you?
No.
Okay. One of the concerns that this patient expressed in the holding area was nausea and vomiting after anesthesia. What are your thoughts about the chances of him having nausea and vomiting?
Well, the fact that he's 26 years old puts him at higher risk for post-op nausea and vomiting. This surgery itself, the knee arthroscopy, is not a surgery associated with higher incidence of post-op nausea and vomiting. So that doesn't concern me. But the fact that he is 26, we've given some opioids which can induce nausea and vomiting. We have desferrin and the nitrous oxide that can induce nausea and vomiting. That's concerning. However, our nitrous oxide level, as I said before, is 50 at higher concentrations. That's when it induces nausea and vomiting. And we are not there. And the oxygen level also, we'd like to try to keep that up because that's been shown to prevent post-op nausea and vomiting.
So we've got a number of factors that go both ways.
Right.
Are you going to help those factors?
I'll help those factors since this patient is 26 and he's concerned about this. I'll give a 1 milligram of ondansetron
Okay.
to try to prevent that.
That seems like a small dose.
It does seem like a small dose, but there have been studies that have shown that 1 milligram is just as effective as 4 milligrams.
Okay, let's give that. So we have high hopes for that 1 milligram. We probably should have listened a little bit more to him. As you'll see, he did have some postoperative nausea, although it was not a major issue. We probably should have listened to his comment that he wanted to avoid nausea and maybe given him a little bit more or given him a second antiemetic drug. So we're concerned about postoperative nausea and vomiting, and we're also concerned about what else?
Amnesia.
Amnesia. Do we have enough anesthetic on board to produce amnesia? Did we give enough, Tracy?
Yes.
Yes, we did. How much do we need to achieve amnesia with desferrin in this young patient?
Well, you have to stay above the MAC awake
Right.
value.
And MAC awake is about 2.5%.
Right.
So we were well above that just with the desferrin alone. And of course, we have added to that the nitrous oxide, which contributes a lesser amount, but still some to the amnesia. What else do we want to consider or anticipate?
Post-operative pain.
Postoperative pain. Okay, let's see what we said about postoperative pain. We talked about anticipating nausea and vomiting. We've dealt with that. Now we got to talk about anticipating pain. What do you consider when you think about pain in the context of this patient in this operation?
So with this patient, he's 26 years old, he's male. Males have slightly less pain, however, Caucasians may have more pain.
So there's some risk of pain with this operation?
Right.
Okay. And yet it's not going to be a major source of pain for him.
No.
So what are you going to do about that?
Well, his respiratory rate right now is 27. So
I'd like to give about 25 micrograms of fentanyl to try to get the respiratory rate down to at least 20.
Okay, let's do that. There's an alternative that you could do, which would have been to give some ketorolac. Is that right?
Right.
How much would you have given him?
0.5 milligrams per kilogram.
Okay. Now let's see if that does the trick. So we've listed some of the circumstances more likely to precipitate pain. Anyone name any other circumstances? Any other factors that are more likely to produce pain? No one else, all right. Most of these factors are fairly obvious. Some are a little less obvious. Females more than males. Does that mean they have more pain? Well, maybe or maybe not. Maybe they just complain more about pain than males do. Race, white complain more than blacks or Asians. Major surgery, more pain than minor surgery. If you got a longer surgical experience, more likely to have pain. If you give intraoperative opioids, you're less likely to have pain. Pretty obvious things, aren't they? If you give an opioid toward the end of anesthesia as opposed to at the beginning of anesthesia, you're apt to have less postoperative pain. So what can we do to manage pain? Well, Tracy outlined what we might do. We can titrate to a respiratory rate. She was titrating to a higher respiratory rate, considering that the pain would not be severe. If we were concerned about it being severe, we might have titrated to a lower rate, perhaps a rate of 10 to 12 breaths per minute. We could certainly give ketorolac in addition to or instead of the opioid. And we could ask the surgeon, we didn't in this case, but we could have asked the surgeon to have put bupivacaine right into the knee space, and that would have helped us in the management of postoperative pain. Now, how are we going to ensure the most rapid recovery from anesthesia? How are we going to do that? We've already done it, haven't we? We've done it by our choice of drugs. And we can also do it by the order in which we decrease the anesthetics that we're giving. So, for example, if we'd been giving isoflurane, we'd be decreasing that because we want to rely more heavily on the nitrous oxide. And the same thing is true of desferrine. We want to decrease the desferrine. So we rely more heavily on the nitrous oxide. We've already argued why the rapid awakening is useful, because it produces a more rapid transit through the perioperative process, from the operating room and through the PACU. And it may be a bit safer. And you saw one other aspect of this in an earlier slide. This is the incidence of pharyngeal dysfunction as a percent of subjects who have this dysfunction as a function of the fraction of MAC awake. This is not MAC awake. So we're already talking about a low concentration. If you're at half MAC awake, you've got pharyngeal dysfunction with isoflurane, with sevoflurane, and with propofol. Even at a quarter of a MAC awake, you still have pharyngeal dysfunction. That's way down in the concentration. That means if there's regurgitation, the patient is less able to deal with it as well as if there is no pharyngeal dysfunction. We want to have a rapid awakening so we get that laryngeal mask airway out. Let's see the removal of the laryngeal mask airway. We've anticipated the issues of nausea and vomiting and of postoperative pain. Now we've got to anticipate a rapid awakening in this patient. Why is that of particular concern in this patient?
Because this is an outpatient procedure and we'd like to get him home as soon as possible.
So he's anticipating going home quickly after
Right.
this. this surgery.
Right.
Now, how are we going to accomplish that?
Well, we're not running any more propofol, but if we were, we would stop the propofol first.
Why is that?
Because it has the lowest MAC weight to MAC ratio.
Okay.
Then we would decrease the desflurane.
And we've already done that a bit, haven't we?
Yes, we have.
Okay.
And then the last thing that we'd turn down or turn off is the nitrous oxide.
Okay, and that's because?
That has the highest MAC weight to MAC ratio.
Okay, so it will come off the quickest to a point where he will respond.
Right.
Okay, looks like we're moving in the right direction. The surgeon says it's now 10 minutes from the end of surgery. We want to get rid of some more desflurane. How are we going to do that?
I'm going to turn the desflurane off.
If you turn it off, won't it go to 0?
No, because we had turned this, the flows down, so it's a low flow system. It'll take time for the desflurane to come off with the low flows.
So changes occur slowly.
Right.
We've used the best part of several drugs in this procedure. And this is a summary of what we've done. We've induced anesthesia with propofol that has lidocaine in it. We've used a bit of fentanyl to allow us several things, including a lowering of the concentration of the drugs that we might otherwise need, drugs such as desflurane and nitrous oxide. We've used 50% nitrous oxide, not 60 or 70 because of concerns about nausea and vomiting, and 50% because we want the nitrous oxide. We want its low expense, and we want the anesthetic contribution, and we want the rapid awakening that's associated with its use. We used 6% desflurane or less because that's all we needed. That's all we needed to achieve the amnesia that we wanted, to achieve the immobility that we wanted. This is not a paralyzed patient. And we used an inflow rate that was less than 1 liter per minute to minimize the expense of this otherwise potentially expensive drug, desflurane. And we did this all via an LMA. Do we have any coughing now? No coughing at all? No laryngospasm?
No coughing.
No secretion problems?
No.
All right. Despite the use of this desflurane, which at this concentration is not a pungent anesthetic and does not precipitate cardiovascular responses that it can precipitate at higher concentrations. Why not use sevoflurane? Why not use isoflurane? You could. Those are both good anesthetics and they're both safe. So why not use isoflurane?
You could, as you said, but because they're more soluble agents, you would have to reduce them earlier on in the case in order to eliminate them by the end of surgery.
And if you reduce them earlier on in the case, you might increase the risk of having patient move. You could say that the same argument could be made for desflurane, that we could reduce it earlier in the case as well. In any case, we could accelerate awakening, but at the risk of movement by decreasing the anesthetic concentrations. The same effect would be present with isoflurane and desflurane. We'd still have the more rapid awakening with desflurane unless you want to repeal all the laws of physics that apply to solubility. Sevoflurane, why not use sevoflurane? Yes?
Be primarily your inability to use low flow state, I would guess, in this situation.
So that's one reason. You couldn't go down to the 600 cc's per minute that we were down to. And you'd have a slightly slower awakening. Okay, we've come to the end of the procedure and we need to take the LMA out. How are you going to do it?
Well, I'm going to deflate the cuff and then take the LMA out.
Okay, the alternative might be to leave it inflated.
Correct.
Is that right? Okay. So we're going to deflate the cuff. It is now deflated. And we've given oxygen, and we're going to take it out. All right, very good.
Okay, if you could hand that back, that'd be great.
Stick it right there.
Okay.
Right in the back.
Thank you. And he continues to breathe. Okay, now let's see how long it takes him to wake up. Let's look at what happens at 3 minutes.
Paul, open your eyes. Your surgery's all over.
God, what a prediction. 3 minutes. On the head. Or is it the nose?
That's it. Paul, are you having any pain?
Oh no, dear.
Are you nauseated at all?
A little bit.
A little bit. Okay.
All right, we're gonna get you to recovery. How are you feeling?
Fine.
You're fine?
So we had, as predicted, a rapid awakening. We had a bit more nausea than we would have liked. We would have liked 0 nausea. But I think we could tolerate a little bit of nausea, as he suggested. One of the slides that I wanted to show you was a slide that we've repeated before, again emphasizing the fact that in this case and overall there is not an issue with the use of an LMA with any of the potent inhaled anesthetics. Doesn't matter whether we're talking about desflurane or isoflurane or sevoflurane. The incidence of untoward events is the same. Same for all of these. Now we're going to go on from here to an alternative recipe that relates to the airway management. This involved the use of an LMA, but we might want to maintain anesthesia via a tracheal tube. What's the difference? What difference do we have to consider if we're talking about a tracheal tube as opposed to an LMA?
More stimulation.
More
stimulation.
More stimulation. A little bit more?
Quite a bit more.
A lot more. Why do you suppose that's true?
Just the place that the tracheal tube rests has more innervation of the nervous system, and you have more reflexes there than you do in the back of the oropharynx where the LMA would sit.
So one argument is God made it that way. That's always a sufficient argument. There's another argument, which is that if you're thinking teleologically, you desperately want to protect that, don't you? And anything that gets into the trachea, you want to expel as quickly as possible. And as you say, then, you want to innervate that area heavily and keep it from being imposed upon by foreign bodies. The stimulation from a tracheal tube is vastly in excess of the stimulation of an LMA, which is one of the great advantages of the use of an LMA. So we may need to consider and anticipate the fact that we need far greater suppression of the airway reflexes when we're putting a tracheal tube in. Is that going to change our pre-anesthetic approach, our induction approach? And if so, how? How is it going to change it? Tracy?
We'll give muscle relaxant.
And what else will we do?
On induction.
Are we going to give more or less opioid?
More opioid.
Much more opioid in that case.
Can you tell me some of the things that you'd like to avoid with your surgery when you're waking up?
I really would like to avoid the nausea. One time I came out, I was real nauseated. Pain, if I can avoid that. I haven't had problems with vomiting, but of course I wouldn't want that either.
Okay. All right. Well, we certainly will help you with those things.
Okay.
You're going to give a little fentanyl? How much are you giving?
Giving 50 micrograms.
Okay.
I'm going to give you some medication that'll help you go on off to sleep. It might sting just a little bit going in, that's normal, and that'll go away as you go on off to sleep. Just keep taking some nice deep breaths. We're going to take good care of you.
Everything's going perfectly. Couldn't be better. Did you feel the sting in the hand? No?
Put some lidocaine in with the Propofol.
That eliminates the sting in many cases, that's right.
Well, can you open your eyes?
Kind of hard to do.
Help you breathe.
How much of this would you like to have?
You have to have 35 milligrams.
35 milligrams of ropeurinol. All right. There's 10, 20, 35.
Twitch monitor on here.
Twitch monitor is coming on. Okay, let's see what we've got. 4 good twitches. You want to give another 50 of the fentanyl? Okay, so we're giving another 50. Why are you giving all that fentanyl?
I'm giving the fentanyl to blunt the response to the endotracheal intubation and also in anticipation of surgical incision.
You don't think these other agents that you're giving are very analgesic or
No.
suppressant of responses to stimulation of the respiratory tract, huh?
Correct.
Okay, let's see what we've got. Heart rate's gone from 92 to 89, a marked drop. The maintenance of anesthesia is going to require much the same thing that we saw during the administration of anesthesia via an LMA. It's going to require a bit more in terms of suppression of airway reflexes, but not much different in terms of suppression of the response to surgery. That's going to be independent of the airway that we need. The one difference is the need for neuromuscular blocking drugs, which occurred in this operation, but didn't occur in the arthroscopy. Could we have done this case without any neuromuscular blocking drugs? Could we have done it without any? Could you have intubated the trachea without any neuromuscular blocking? Is it possible? Is it really possible? Yes. What would you have done if you really wanted to avoid any neuromuscular blocking drugs?
Deepen the anesthesia.
Deep what?
Deepen the anesthesia that you give
Okay.
for induction, either through the inhalational agent or through the amount of propofol that you give.
So you might have given 3 milligrams per kilogram instead of 2 milligrams per kilogram. That's right. We could have done that at the risk, of course, of, as I think it was you that said that, a greater incidence of hypotension. Okay, let's consider more about maintenance of anesthesia. Okay, we've been going for about 15, 20 minutes now. What's happened to the blood pressure and the pulse rate?
Blood pressure and the pulse rate are, have dropped a little bit since there's no stimulation between induction and...
And she was a little hypertensive, so this is relative hypotension. Are you concerned about that?
I'm not concerned about that in this patient. She will be getting stimulation soon when they start the procedure.
Right. And we've accomplished what in the way of nitrous oxide and desferrine?
You can see that entitled nitrous is at 55% now, and desferrine is at 3.8%.
Okay, and we're delivering 3 and 2, so we're delivering actually a higher nitrous oxide concentration than that reflects.
Right.
Why is it higher? Or why is that lower?
Well, the entitled reading's lower because the patient's taking up nitrous at the beginning of the case.
And are you at the desferrine concentration you want?
Right now, yes.
That's giving you enough of a MAC?
Yes.
You think we could economize now?
Sure, we could turn the flows down.
All right, let's do that.
All right.
What are you going to go to?
I'm going to go to a total of 1 liter. So I'll go to 0.5 of nitrous and 0.5 of oxygen.
Okay, sounds good. Do you think you're going to have to turn your desferrine concentration up?
Not right now, I don't need to turn the desferrine.
Not right now, but you might as time passes, because with a lower flow rate, there's going to be more rebreathing.
Correct.
Okay. And surgery is about to begin. We move rapidly to recovery, and consider that the things that we talked about when we talked about an LMA in recovery are no different. We've got to consider postoperative nausea and vomiting more in this case than in the previous case, because why? What did she warn us about? She'd been nauseous before. We've got to be concerned about pain, probably a bit more than in the preceding procedure. We've got to consider the rapidity of recovery, and in addition, we've got to consider the removal of the tracheal tube. And the removal of a tracheal tube can present a problem with poorly soluble anesthetics. We saw that in one of the previous illustrations, where removal of a tracheal tube after sevoflurane anesthesia was associated with laryngospasm. Why does that occur? And why does it also occur with desferrine? Why is it an issue? Anyone?
Quicker transit from an anesthetized to a wakeful state, so you're more quickly aware of having the endotracheal tube.
And you remember
or foreign body in your trachea.
That's right, and you remember it. If that's the case, then the way to manage it is obvious. The way to manage it is to not allow that lightening to occur. So you could maintain the anesthetic at a deeper level. But if you do that, that may delay by just a few minutes, perhaps with a poorly soluble agent, but it may delay the recovery a bit. Or you can allow the lightening to occur. You can taper or glide in, as you would with any of the potent inhaled anesthetics. And then at the last minute, 30 seconds before you remove the tracheal tube, give a very small dose of propofol, maybe 10 milligrams of propofol. Or you could give some intravenous lidocaine. There have been those who've advocated the use of intravenous lidocaine, and most of them have found that it's ineffective. I think the problem is not that it's ineffective, but if you give too small a dose, it's ineffective. Too small a dose is 50 to 100 milligrams of lidocaine intravenously. Be a woman and give a big dose. Give 150, 200 milligrams of lidocaine intravenously. And that will also minimize coughing after removal of the tracheal tube. And if we have given opioid for management of pain, that in itself may deal with the issue of coughing with the removal of the tracheal tube. Now there's a further point that I want to make that isn't as specific to coughing as these approaches are, but it has to do with the safe removal of the tube. If you're going to remove a tracheal tube, the way to do it is to deeply inflate the lungs immediately before you remove the tube, and then with the lungs inflated, remove the tube. Don't remove the tube after you've allowed the lungs to return to FRC, but remove the tube after you have inflated the lungs deeply. With the lungs deeply inflated, the tube comes out, and what's the first thing then that the patient has to do? Exhale. Exhale. You've got to breathe out before you can breathe in again. And if that's the case, then the exhalation will push forward and up into the pharynx any phlegm that might exist in the larynx. And with that technique, I find there just is not an incidence of laryngospasm, a problem with coughing. We've got 4 twitches on the train of 4, and the fade doesn't look bad. I thought that the train of 4 showed some fade, though.
Right.
How are you going to deal with that?
Since the procedure's almost over, I'd still like to give some reversal.
Okay.
So I'll give a milligram of neostigmine with 0.2 of glycopyrrolate.
That's much less than the usual standard dose of neostigmine.
Yes, it is. But as you said, she didn't have a lot of fade. I don't think she needs the full dose. The full dose of neostigmine would predispose her to post-op nausea and vomiting, which we're trying to avoid.
Now we're almost at the end. We want to do 4 things. We've done the anticipation of nausea. We've done the anticipation of pain. Now we're getting an anticipation of rapid recovery. And how are we accomplishing that?
Well, we have already done some things as far as the medications we've given her. We've given her Propofol, which comes off rapidly. We're using Desferrine, and we'll turn the Desferrine off, and then the nitrous oxide off.
Because?
The Desferrine has a lower MAC awake to MAC ratio.
Okay. And now we're going to anticipate removing the endotracheal tube.
Okay.
And she started to cough. We better deal with that.
All right.
We're going to give her what?
20 milligrams of Propofol.
We just did that. Okay. And in 30 seconds, we're going to remove this endotracheal tube. We could take the air out of the cuff. We're going to turn up a high flow of oxygen. We have suction the back of the throat. Okay. And now we're going to remove that endotracheal tube. We're going to do it by giving her a deep breath and removing the tube at the peak of inspiration. Okay. Okay, you able to ventilate her?
Can I have an oral airway?
In an oral airway. Okay. Ready? That better? You can see the chest rise. Okay. So she didn't cough when we removed the tube. She was coughing right before we removed the tube.
Correct.
And now you're able to ventilate her. And the anticipation is that she'll be awake in what?
She'll be awake in a few minutes.
A few minutes. Do you want to guess precisely?
No, I'll let you do that.
All right. I'll bet she'll be awake in 5 minutes. Let's just see.
Can you open your eyes? Open your eyes for me. Your surgery's all over. Open your eyes.
Very good.
Good.
Ask her if she'd like the oral airway out.
Well, I'm going to take this out of your mouth for you. Open your mouth. Very good.
Can you open your eyes for us? Good. We're all done. What do you think? You having any pain? Having any nausea? Okay. Everything went very well. Very well. Do you think you could move to the table that's to your right, or left rather? Okay, let's see you do that. Just raise your knees up. You can take my hand here. That's it. Lift yourself over to this table. That's good. Just come right on over. A little further. Okay.
Keep coming.
Keep coming. That's right.
Great.
Perfect. All right. Say hello. Louder. You got to say it louder.
Hello.
All right. Hello, world. I'm glad to be back. So the additional issues that we haven't really covered are some details on dealing with the neuromuscular blocking drugs. You saw some of that. An issue that we didn't talk about at all was avoiding hypothermia. And that's an important issue that we need to discuss as part of the ideal anesthetic. Why is avoiding hypothermia important? Why?
It can cause post-op bleeding or bleeding and infection.
So it's been noted to be associated with those two things, bleeding and an increased incidence of post-operative infection. It also may affect the immune system, and it may cause the patients who awaken to shiver, and that is something we don't desire, increasing their metabolic rate and making them uncomfortable. What if we couldn't give nitrous oxide? What would you do then? How would you deal with the requirement for anesthesia? We found nitrous oxide to be an important part of this anesthetic, but could we do without it? Yes, we can do without it. What do you have to do then? Tell us, Quinn, what are you going to do?
Well, you can use desflurane alone and get almost as rapid an emergence, or you could use a balanced technique such as combining desflurane with remifentanil or propofol.
Yeah, so there are many ways to skin a cat. Okay. I think we've heard some interesting comments from you about your own recipes, some suggestions that some of you might prefer sevoflurane or might prefer to use isoflurane. And there are good reasons for those choices. Each of us have different prejudices. And I've provided you with mine, and I've provided you with some of the rationale for each of those prejudices. I want to emphasize that the recipes that we all may have to be tailored to particular patient needs. And you saw some of that in the ideal anesthetics here. I want to thank you all for your participation in this. You now, I think, have some ideas that perhaps might alter a little bit or a lot your approach to the ideal anesthetic in your hands.